Stroke is a devastating disease that affects about 800,000 Americans nationwide each year. It is the fifth leading cause of death and the second leading cause of disability. A stroke occurs when the blood flow to the brain is interrupted by a blocked or burst blood vessel. Stroke patient care starts with patient comprehension of what symptoms they should be aware of. An easy way to remember this is the FAST acronym. That is F for face drooping, A for arm weakness, S for speech difficulty, and T for time to call 911 if you see anyone with these symptoms. Once a patient is evaluated by a paramedic and a stroke is determined, they will indicate a stroke alert, or code stroke, to the closest primary or comprehensive stroke center with the LKN, which is the last known normal time frame. The EMS team will then get contact information on the next of kin, start two 20-gauge IV lines, check glucose level if possible, and perform a Van scale to identify if they are a candidate for a thrombectomy. The Van scale is an acute stroke screening tool used in the field to determine the severity of a stroke. It consists of checking the patient for arm weakness, visual disturbance, aphasia, and neglect. We will now show you the proper way to perform a Van scale assessment. In this demonstration, our clinician first asks the patient to hold both arms in front of them as she counts down from 10. As you can see, the patient displays arm weakness in their right arm, which indicates to continue. If no arm drift were present, the patient would then be considered Van negative. Next, the clinician begins the vision portion of the exam by asking the patient to look at her nose and reply with how many fingers she is holding up. She holds up fingers in 4 parts of the patient's visual field: upper and lower right, and upper and lower left. She then asks the patient to track her finger with their eyes, moving her hand across their visual field. In this case, the patient displays loss of vision in her right visual field. The clinician then performs the aphasia portion of the exam, which is the inability to comprehend and form speech. She asks the patient to follow 2 commands. The first, to close both eyes tightly, and the second, to make a tight fist. In this case, the patient was able to perform both commands. Lastly, the clinician performs the neglect portion of the exam to check for sensory deficits. She uses a small object to tap the patient on both arms and legs, asking each time if the patient could feel it. In this case, the patient could not feel with her right arm and leg. Since the patient displayed symptoms in addition to arm weakness, she is diagnosed as Van positive. If the patient displayed arm weakness but showed no other Van symptoms, she would have been diagnosed as Van negative. Once the patient arrives at the hospital, the emergency department team will quickly evaluate the patient with a blood glucose test, a 12-lead EKG, CBC, BMP, PT or INR, and PTT. The nurse will then perform a NIHSS assessment while the physician screens the patient and updates the neurologist. If a neurologist is not on site, most hospitals have the capability to provide telestroke care through a Skype-like service. This allows the physician on site to relay information to a neurologist and ensure proper stroke care. There are 2 types of strokes, hemorrhagic and ischemic. A hemorrhagic stroke occurs when a weakened blood vessel ruptures. This is usually caused by uncontrolled hypertension. An ischemic stroke, which accounts for 87% of all stroke cases, occurs as a result of an obstruction within a blood vessel supplying blood to the brain. Both types of strokes are detectable through a non-contrast CT scan. During the first 3 to 4.5 hours after stroke onset, patients are eligible to receive recombinant tissue plasminogen activator, better known as TPA. Patients who receive TPA statistically have a 30% more favorable outcome with minimal or no disability at 3 months. Those eligible must be over 18 years of age, have a last known well time frame less than or equal to 4.5 hours, no bleeding indicated on the CT scan, and patient and/or family should understand the potential risk factors. The patient is then taken to the angiogram suite, where the neurointerventional radiologist will perform a thrombectomy. A thrombectomy is a type of surgery used to physically remove the clot from the blocked artery or vein. The CT angiogram shows the clinical team where the blockage is located, while the CT perfusion will detect what tissue is salvageable, the penumbra, and what is infarcted. This is done by injecting dye to show which areas of the brain are adequately supplied or perfused with blood and which are not. The penumbra is the zone of reversible ischemia around the core of irreversible infarction. In an effort to save the penumbra, the first few hours of an ischemic stroke are crucial. Once a patient is treated, the stroke care continues in the neuro-ICU and neuroscience floor with a team of trained professionals working together to provide guidance for rehab. Clinical trials such as ESCAPE, Extend-IA, Swift Prime, and Revascat, to name a few, have achieved approval of endovascular treatment and thrombectomy for ischemic strokes with or without IV TPA if within 6 hours of the onset stroke symptoms. Prior studies have indicated a clinical advantage to performing thrombectomy within 6 hours of stroke onset, with decreasing clinical benefit as time to thrombectomy increases. After 6 hours from stroke onset, relatively fewer studies are available to aid in determining optimal stroke management with thrombectomy. In the DAWN trial, it compares stroke patients with a mismatch between their clinical deficits and infarct volume, treated 6 to 24 hours after symptom onset with thrombectomy plus standard care, compared to standard care alone. This study provides significant evidence supporting thrombectomy treatment between 6 and 24 hours after stroke onset. The treatment effect size is the highest out of any stroke trials to date, which suggests that the presence of clinical core mismatch is a critical predictor. Similar to the Swift Prime and Extend-IA trials, the current Diffuse 3 trial examines the window between 6 and 16 hours using CT perfusion. Endovascular therapy plus medical therapy, compared to medical therapy alone, was associated with a favorable shift in the distribution of functional outcomes and a higher percentage of patients who were functionally independent. The 90-day mortality rate was 14% in the endovascular therapy group and 26% in the medical therapy group, with no significant difference between groups in the frequency of symptomatic intracranial hemorrhage. Due to new studies and updated stroke guidelines, more patients are now eligible for crucial treatment that could save their lives. Whether you are a patient, family member, or first responder, it is important to watch the clock and pay attention to the onset of stroke symptoms.